All right, let's dive right into this explainer. The human body is basically a marvel of biological engineering, and a lot of that comes down to a highly complex plumbing system. When it's working, it's an absolute masterpiece. But when those fluid levels get thrown off, well, that's when we see a massive cascade of clinical emergencies. Today, we're taking a close look at exactly what happens when that delicate balance is broken.
So, here's our roadmap for today. We're going from 1. The basics of blood volume, to 2. Hypovolemia, 3. Hypervolemia, 4. Complications and warning signs, 5. Diagnosing the imbalance, and finally, 6. Restoring the balance. Let's get to it.
Section 1. The basics of blood volume.
To start things off, we have to ask a fundamental question. What actually happens when the body's delicate fluid balance just goes completely off the rails? It's a fascinating question, and really, the answer comes down to two absolute extremes. You are either incredibly dry or you're completely overflowing.
The first extreme is hypovolemia. This is literally losing the liquid that keeps our vital organs perfused. It happens when the amount of fluid actively running within our bloodstream drops significantly below normal levels. Think about it like a house with low water pressure. Without enough fluid in the pipes, the pressure tanks, and critical organs simply do not get the oxygen they need to survive.
But if we swing that pendulum to the exact opposite side, we hit hypervolemia. These are states of severe fluid overload. Now, this isn't just about drinking too much water. It's a pathological state of fluid retention. The body aggressively hoards sodium and water, which expands the blood volume way beyond normal limits, and eventually that fluid starts leaking out into places it definitely shouldn't be.
Moving on to Section 2. Hypovolemia, losing the liquid.
So, how does the body actively lose all this critical fluid? It basically escapes the circulation through one of three paths. First, through the kidneys. Think of diabetic ketoacidosis, right? High blood sugar literally acts like a giant sponge inside the vessels, dragging massive amounts of water straight out into the urine. Or it could just be from overusing diuretics. Second, we have extrarenal losses. This is fluid violently exiting the GI tract, severe vomiting or diarrhea, or evaporating right through the skin from excessive sweating or extensive third-degree burns. And finally, there's third spacing. This happens during massive systemic inflammation, like in severe sepsis or pancreatitis. Cytokines get released, the capillaries get super leaky, and the fluid just oozes out of the blood vessels, getting dangerously trapped in the interstitial tissues. So you aren't necessarily losing the fluid out of your physical body, but it's removed from your circulation. And honestly, that drops your blood pressure just the same.
All right, Section 3. Hypervolemia, the fluid overload.
Now let's look at the other extreme, where the whole system gets backed up. What's truly wild here is the body's internal hormonal cascade, the RAS system, that stubbornly locks sodium and water inside. When the kidneys sense a drop in blood flow, they hit the panic button, hard. The JG cells start pumping out an enzyme called renin. This kicks off a chain reaction, forming angiotensin II, which then triggers a massive release of aldosterone and ADH, antidiuretic hormone. Aldosterone basically yells at the kidneys to reabsorb sodium, and ADH tells them to grab all the water. All of this extra sodium and water dumps right back into the bloodstream, dramatically expanding your intravascular volume.
But here is the ultimate paradox. Conditions like congestive heart failure or cirrhosis actually reduce your effective circulating blood volume. In heart failure, the pump is broken, so cardiac output is low. In cirrhosis, blood pools in the GI vessels and albumin levels drop, meaning the fluid won't stay in the vessels. Because less blood is reaching the kidneys get totally tricked. They think, oh no, we must be dehydrated. So they fire up that exact same hormonal emergency cascade we just talked about. They start hoarding even more fluid that the body absolutely does not need, and that leads to massive, catastrophic fluid overload.
Section 4. Complications and warning signs.
With those mechanisms established, let's talk about what this actually looks like in a patient. Clinically, these physical extremes couldn't be more different. In hypovolemia, your body clamps down tight to save the core. The sympathetic nervous system constricts blood vessels in the skin, so you end up with cold, pale, and mottled extremities. You'll see bone-dry mucous membranes, decreased skin turgor, and a delayed capillary refill. But in hypervolemia, the patient can look incredibly puffy. All that hoarded fluid leaks right out into the tissues. It backs up into the lungs, causing pulmonary edema. You'll hear crackles on a stethoscope. It backs up into the neck, causing jugular venous distension. It pools in the abdomen as ascites and sinks down into the legs, creating severe pitting edema where pressing on the skin literally leaves a deep indentation. Now, when vascular volume drops significantly in a hypovolemic patient, 65 is your stark, non-negotiable clinical threshold. A mean arterial pressure, or MAP, below 65 millimeters of mercury means the patient isn't just hypotensive anymore. They're entering life-threatening shock. They simply don't have enough pressure to drive blood into their vital organs.
And if that organ perfusion drops too low for too long, the tissues are forced to switch from normal aerobic metabolism over to an emergency anaerobic process. This backup system produces lactic acid. When you see lactate levels climbing dangerously above 2, it's a glaring, flashing siren that the body's tissues are literally starving for oxygen.
Section 5. Diagnosing the imbalance. So how do we actually confirm which plumbing disaster we're dealing with? Interestingly, both severe hypovolemia and hypervolemic states like heart failure can cause what's known as a pre-renal acute kidney injury. Because the kidneys are starved of effective blood flow in both conditions, they can't filter waste properly. So you'll see elevated BUN and creatinine levels in the blood. But here's the brilliant diagnostic clue: the fractional excretion of sodium, or FeNA. Because the kidneys are desperately trying to rebuild blood volume, they aggressively hold on to sodium. When you check the patient's urine, the FeNA will be less than 1%. There is hardly any sodium in there at all.
While all those complex lab values are great, sometimes the absolute best tools are the simplest ones. Seriously, strict tracking of what goes in, what comes out, and the patient's daily weight changes is remarkably effective. If a patient is dropping weight daily and their fluid output is way higher than their intake, they're drifting toward hypovolemia. If they are packing on pounds and holding on to fluid, you're looking straight at hypovolemia. It's the ultimate truth teller. Which brings us to Section 6, restoring the balance. The final piece of the puzzle: how do we clinically fix the broken plumbing? Depending on the patient's state, you have very specific fluids to reach for. If the patient is dry and crashing, low blood pressure, high heart rate, maybe a high lactate, you prioritize isotonic solutions. Things like normal saline or lactated ringers for immediate hemodynamic rescue. These replace the blood volume directly. But if they're mostly just dehydrated with severely high sodium, you might use hypotonic solutions like D5W to give them pure free water. And what about our cirrhosis patients whose fluid is leaking because they lack proteins? Well, we might reach for a colloid solution like albumin to help actively pull that fluid back into the blood vessels.
Conversely, if the patient is overloaded, you use a step-up approach to augment your diuretics. It's almost like a ladder. You start with a loop diuretic to force the kidneys to dump water. But of course, diuretics mess with your electrolytes. It's like whack-a-mole. If the patient's sodium starts climbing, you add a thiazide diuretic. If they start losing way too much potassium, you add a potassium-sparing drug like spironolactone. And if their body becomes too alkaline, their bicarb goes up, you add acetazolamide to correct it. It's a very delicate, constant balancing act to counter the massive electrolyte chaos that ensues.
Real quick, here's a fascinating clinical pearl regarding that base loop diuretic, furosemide. It's famously known by its brand name, Lasix. Do you know why? Because the diuresis effect beautifully lasts for about 6 hours. Last 6. Last 6. It's a brilliant little trick to remember how frequently you might need to dose it to keep pulling fluid off a puffy patient.
But what happens if you max out that entire diuretic ladder, and the patient is still overloaded, still acidotic, and their kidneys have basically just thrown in the towel and stopped making urine? When the pharmacological plumbing fixes completely fail, the only remaining option is bypassing those broken biological filters entirely with hemodialysis. You hook the patient up to a machine, pull their blood out, artificially cleanse it to remove the extra fluid, and pump it back in.
Which leaves us with a fascinating final thought. When we aggressively push IV fluids to fix low blood pressure, or when we bombard a patient with massive diuretic combos to drain away swelling, are we truly fixing the underlying volume disease? Or are we just temporarily patching the pipes in a system that is actively fighting against us? It's definitely something to think about the next time you look at a simple bag of IV fluid. Thanks for joining me on this explainer, and keep questioning how everything connects.